And I too congratulate everybody who's made it this far into the meeting. This is going to be a slightly unique talk. This is, I was asked to speak on checkpoint blockade and beyond, but it'll be talking about blockade, but it's a clinician's perspective. I'm not an immunologist. This is the way a clinician who sees patients with these new drugs, how I deal with patients. So the topic, the schema will be talking about carcinogenesis a little bit and cancer plasticity. We'll talk about normal cancer immune function. We'll look at some checkpoint blockade and balances, but it really is checkpoints and balances. That is the theme of the immune system. We'll talk a little bit about mutations as a driver of immunity, heterogeneity, MSI, T-cell function, and then where we're going to be going with all of this, we hope, is going to be combination therapies, but they are going to move from we just kind of give a drug for anything to true precision medicine. We will have immunoprofiles in the near future that will go ahead and that will tell us what the right thing is to treat patients. So disclosures, I have a number of clinical studies that we're involved with. And as a clinician, the way I see carcinogenesis is we make cancer cells every day. DNA repair is the critical issue, and sooner or later DNA repair doesn't work, and suddenly we have, quote, cancer. At that point, it's the immune system's responsibility to understand that something is now immunogenic or is not normal, and therefore it's the immune system's responsibility to take care of it. And as those two work together, we manage to keep ourselves cancer-free, at least through time. And so at this point, we are trying to practice precision medicine. We are running a molecular panel that predicts what gene mutations made the cancer, but we're at the starting point of having discrete immune panels. They largely consist of absolute absolute lymphocyte count for potentially CTLA-4 or PD1 measured therapy as an immune panel. But now these two panels are becoming overlapping, and we are looking at, when we count mutations, we can say more mutations makes the cancer more immunogenic. And so while I thought at one point we'd have independent panels, I think we're going to end up with a biomarker panel that goes across everything. So cancer is, so I was real excited with cancer years ago when we started off with these molecular markers and we'd see an ALK mutation or a BRAF mutation, but I have to admit I was pretty upset as we thought more and more about heterogeneity. The concept of heterogeneity says that whatever's there is going to adapt as time goes by. We'll kill off the easy clones and we'll be left with the not so easy clones. And so just these two studies that I've listed here, one is in kidney, and it talks about heterogeneity, something that's been mentioned already today. But on one side versus the other side of the tumor, there'll be different genetics. From the metastasis to the primary, there's different genetics over time. There's different genetics, patient to patient. And in lung cancer, we can see that there's a same paper referenced by Govindan. There was differences in genome doubling time, subclonal mutations, and the like. So you look at this and you say, gee, this is a real problem. How can even the immune system solve this? And there's advantages to the immune system in these situations. The more the cancer mutates, the greater, or the more it is different than self, and the greater the immune system can participate. And the immune system doesn't just have to follow genes. It can create an inflammatory environment, and that inflammatory environment can take out cancer cells that may or may not have the correct mutation. So I see great promise in this, and I think this isn't the slide set that I had planned on, so we'll see how it goes. but we'll continue. We'll go through it. So cancer heterogeneity, we just said some of this already. We mentioned that, the more heterogeneity it is, the better it is for the cancer to grow. There's greater diversity, the cancer evolves and adapts, and drug resistance develops. And on the other hand, as I said, the cancer can create problems for itself. It can potentially induce immunogenicity. So where have we gone with immunotherapies? Well, this slide has been shown many times today by all the different disease groups. And how can the cancer bring itself into getting in trouble with immune therapy to make immune therapy more effective? Well, if you look at this, it shows a mutational load, and it shows that the order that the drugs are being approved, right? The more effective the drug is, the easier it is to do the study, and the faster you'll get the drug approved. So you can see right on down the list, melanoma, all the different non-small cell lung cancers, and then bladder cancer coming along. So this is an effective means of treating patients. Adaptive immune system, this is the way we reflect it to everybody. There is a cancer cell followed by an antigen-presenting cell, and this stimulates the immune cells to kill the cancer. And eventually, I think if I can see it correctly, a T-cell is developed. And now I have a memory T-cell. And the goal is I'm supposed to activate my immune system, but not just to go and get a quick response, to be able to come up with a memory T-cell that replicates itself and kills cancers over the course of the patient's lifetime. So this is always represented in a linear fashion. But Chen and Melman, I think, have been very good at putting out slides to influence all of us. And they've taken that exact same linear slide and turned it into a circular slide. And it says all the same things, that antigens released, that there is priming of cells within the lymph node area, and the tumor cells, or the immune cells, have to get to the tumor cells via the network. And the tumor cells are killed. But the point that I think is important is that that these cancer cells that are now being killed by the immune system release more immunogenic, create immunogenicity in their own right. So there's a potential for feedback here, and with the right influence or the right set of circumstances, this immune system can feed back on itself and create even more killing. And the tightly balanced that I mentioned, well, if you look at every one of these 7 steps, the green says these are stimulatory molecules, and the red are inhibitory. And so while we think in just terms of PD1, there's way more than this, that every single step has got a series of positive and negative regulators. And if we believe that this is truly a cycle that can feed back on itself, it says any little influence we make at any one of these steps could turn this system from an immune cancer relationship that's losing to an immune cancer relationship that is in fact going to become a positive feedback and become a true killer of cancer cells. And these are just some of the drugs that are in the market, and you can see that there are drugs being developed or at least studied in every single area of these potential therapies. Now, I don't believe there's just 7 steps in this. I believe there's many more, but there's going to be checks and balances at all of these levels. We're kind of lucky, right? We throw something into this whole soup and it works out. It's just great that the body is self-correcting. So we've been treating immune therapy for quite some time. You can see this dates back to 1890s, so there's been all kinds of strategies. But the big difference now is that we've taken a different strategy. It used to be, let's go and measure something that we understand, and let's make it in industrial doses, and then let's give it to the patient and see what happens. Those who've worked with interferon over the years know we can make patients sick and suicidal. Those who've worked with IL-2 in the intensive care unit know that you can kill patients just with immune activation. So it's a terribly challenging event. The strategy here is completely different going forward. We're taking a natural activation with the PD1 inhibitors, and then we are inhibiting the inhibitors. So the strategy is very different. Instead of industrial doses, we still do industrial dose therapy, but I think we are acting or behaving more physiologically going forward. And that, to me, is the big difference. So the immune system in its natural state, as I said, tightly regulated. We showed that in the last slides. But it's got a job to do, and it's got to be totally balanced. Its job is to eliminate foreign bodies. This could be any sort of infectious or object that the body may be exposed to. It can also be cancers, but too much autoimmune is autoimmune disease, and those patients who come to see me with autoimmune disease pre-existing show me diseases that are every bit as bad as cancer. So everything has got to be tightly regulated. The checkpoint inhibitors that we have now are two, CTLA-4 and the PD-L1 axis. And as we stated, the antigen-presenting cell communicates with the T-cell through CTLA-4, but as soon as the body has been activated, within days, CTLA-4 is present on the T-cell, and it's downregulating itself. And so natural activation and then prevention of the downregulation through CTLA-4. The same goes on with our checkpoint inhibitor, PD1, and except this is at the tumor level or the tissue level. And so activation naturally, but then prevention of downregulation. And how good are these therapies? People have the idea that these are fantastic and wonderful, and if you treated melanoma a few years back, it is, because nobody was doing that well then. But you can see here that a small fraction of patients will benefit, but they can benefit forever. And of interest in the CTLA group, they get 4 doses, and they have developed these memory T cells. And after 4 doses, it's one and done. So there may be T memory cell activity with this that's greater in this therapy than it is with the PD therapies. Not in the order I was planning, but we will work with this slide set. So this is just to go and point out that our T memory cell is the key element in all of this. And there was an argument over time that T memory cells may not really happen until you manage to get to the point where you've killed off the appropriate antigen. It happens later. But what this slide is trying to show is that T memory cells can occur early in the naivete or the differentiation of T cells. And it's also meant to show that a T cell, again, I can't see this, but I will tell you what I remember. A T cell that does become activated, will start to show a lot of, or does become exhausted, will start to show PD marker on its surface. And so it's telling you, if you have a PD marker, that very likely that's the way the cancer is getting around the system. But it had to have been active largely in the first place, and that cells can become exhausted, and this slide over here is to show it, where it can't be retrieved. So memory cell is important, and PD can play a role in this along the way, but it's not the whole story, and I've got some ligands listed below that. So the PD1 inhibitors, you've seen some of these slides, and the top is the Bristol studies. It's Nivolumab, and these are 3 studies in second-line lung cancer. And what it really says is that in second-line lung cancer, these therapies beat chemo flat out. The interesting part is by the time you get to the third study here, atezolizumab, they use biomarkers to separate this out. And I'm hoping the next slide is the biomarkers that I was going to talk about. Good. So this is almost counterintuitive. This was presented at ASCO, and people really didn't think about it a whole lot. So let's see, down here, what it shows is that, maybe I'll look with everybody else. What it shows over in this area is that any biomarker that shows up that we've been using, any one shows a greater improvement in general. And that makes sense. The biomarkers do work, but they're not perfect. You've heard or have seen that anytime there's a PD-L1, or you look at any study, there's always some PD-L1 negative patient who does better than everybody else. So that's not the whole answer, but each of these contributes. And then secondly, there are biomarkers on the tumor cells as well as the immune cells. And this one is interesting to me. We have the Venn diagram that shows how positive these cells are. And what's interesting is at the 1+ level, the tumor cell, the immune cell, they're both demonstrating the biomarker. At the 2+, the Venn diagrams are starting to separate. And at the 3+ level, really interesting that either the tumor cells are showing it or the immune cells are showing it. Potentially an answer for why PD-L1 negative tumor cells could still have a fantastic response, because those with the immune cell biomarker did better. And by this definition, this of the 4 assays for PD-L1, this is the one that's supposed to be have the poorest correlation with the other 3. But maybe it's having the poorest correlation because it's measuring something that's important. They measure both tumor cells and immune cells. The other half of this are another whole series of biomarkers that include interferon and the body's, the T-cell's ability to go ahead and generate a functional display, so that it's not just a PD positive cell that you are seeing. It is something that can still generate cytokines that cause cancer death. And while I can't see the rest of this, it shows that there's a whole series of biomarkers that are here. It's not just about PD1, meaning we don't understand our full cell kill very easily. So that's second-line non-small cell lung cancer. If you jump into first-line non-small cell lung cancer, again, you've heard this. If you pick the patients who are strongly PD-L1 positive at the 50% level, very interesting, because we started off saying, well, Bristol Myers, or that thought we could get away with it, without it. The pembrolizumab group used a 1%, but now they've shifted to a 50% number. So it's a dynamic state. We don't know that 50 is any different than 51, but the idea of more of it is probably better, and that's understood. So great responses. This stuff works in first-line therapy as a PD1 inhibitor. However, Nivolumab as a PD1 inhibitor didn't work, again, shown already. It didn't make a whole lot of difference. So are these 2 agents the same, or are they different? It's not clear, but it may well mean that the biomarker is not the whole answer for this, because at the AACR meeting this year, they did a reevaluation of this and looked at those patients who were PD-L1 positive, as well as having high tumor mutational burden, i.e. being more immunogenic. And essentially, while it's a reevaluation of a pre-existing study, essentially it takes a negative study and makes it positive. Again, the whole point is I don't think we understand what we're talking about just yet, but there will be a whole slew, there will be an immune panel that will be able to go and sort this out. So that's at the tumor cell level, but what about in the microenvironment? And this slide again is here to talk about an inflamed tumor population with an inflamed tumor that has white cells, T cells, other cells present, versus that which has no cells present, the desert, versus one that's sort of in between. And there's going to be biomarkers in this that we will be able to separate out. But you have to have of interest, at least at this point, with these PD1 therapies, the body had to figure out how to mount its own immune system in the first place. If there are no tumor cells within the tumor, all of the PD1 therapy at this point by itself won't be effective. And it's not just the cell, it's not just these epitopes that are important for the T cells. There's a whole group of negative regulator cells. So there's Tregs and TAMs and myeloid-derived stem cells. If they're present in the tumor, they are negative or they are inhibitory to the immune system. These have got to be measured. So where I think we're going to be going, let's see. So personalized immunotherapy is where I believe we're going to go. We know that the responders have an inflamed tumor, but that alone is not sufficient, that there are other biomarkers within the soup that measure functional assay or immunogenicity. And the non-responders, there are negative inhibitory signals as well as negative cellular inhibitors that we're going to have to measure, and we're just not doing those at this point. But people are postulating that we have an immunogram. So instead of, as I said, just saying PD-L1 positivity, I think we're going to be measuring on those 7 elements that we have discussed in the past. And it'll tell us who's likely to benefit from a traditional therapy, but at the same time, it could tell us what it is we are missing from this traditional therapy and what should be added in to make this therapy effective. And it's more than that. So this here is the yin and the yang of the immune system. But we all have a set point in our life that changes. So while I can't read this and I'm going to cheat and look, it argues, I think that, so it says our genetics will change over time, our age will change over time, I can't read what that says, but our basic immune function will change over time. So we sort of live at an immune status that will decline with age. And so a little bit of stimulation in one population may not be what's needed for the next population. So I do believe an immunogram will be where we're going. So beyond PD1 therapy, this is an effector T-cell, and it lists, and I saw this slide already once today, but it lists a whole group of activating receptors for the T-cell, and there are drugs that are being developed against all of these to further activate the system. And then on this side are the inhibitory receptors for the T-cell, and there are drugs there being developed in all of these that are inhibiting the inhibitors at this time. At my own institution, we are doing everything so where do you go next? The next step is combination. So the prior study would argue single agent would be where you'd go, but combination's probably where we'll end up. And we are now routinely treating our patients with LAG, IDO, TIGIT, OX40, TIM, and even Coxsackie virus studies. We've got 2 or 3 different viruses that we are now treating the patients with. So I think combination therapy will be the answer to everybody. But combinations can come in all different flavors. You've seen that Nivo-Ipi beats Ipi. So the combination of existing IO drugs, both on the market, can be combined. And at this year's AACR meeting, it showed an improvement in overall survival. So the combination of IO on the market, so in addition to all of the studies that you're seeing, IO, there will be IO, who's on the market already. And the same is true in small cell. These are approved at this point. The combination is recommended by NCCN, although FDA has not yet gotten there. And radioimmunotherapy is going to be interesting as time goes by. This left-hand slide is probably the most reported case report in the history of the world. This was in New England Journal like 4 or 5 years ago, but it was a patient who'd had ipilimumab therapy. It stopped responding, got a round of radiation, and suddenly reignited the patient's immune system. And there are studies looking at this. It was also mentioned in lung cancer that one doesn't have to do them concurrently, that in fact radiation therapy in regional cancer, so stage 3 unresectables, with the randomization to durvalumab subsequently, is showing an improvement. So perhaps it's not just the immunotherapy on top, but in fact the therapy before that's influencing this therapy afterwards. And then chemo-immunotherapy, the Langer study has been touted that we can combine chemo with immunotherapy. Both Govindan and Renato mentioned that the combination of chemo-immunotherapy resulted in, for lung cancer, remarkable response rates in the 55% range. And in the waterfall plot, Renato pointed out that only one patient in the chemo-immuno actually grew in therapy. That's better than leukemias almost. I mean, I don't expect that we can reproduce that, but we are now putting out hypotheses that say maybe we can. So a couple of slides aren't really here, but anyway, as an immunotherapy therapy summary goes, we have to think of this as a network. There is substantial feedback on itself. Everything is a finely tuned balance. I think we've been fortunate so far that any perturbation we've introduced could have resulted in excessive toxicity. Remarkably, we haven't seen the toxicity that many people were worried about. The biomarkers will characterize the cancer, but we're going to have biomarkers that are going to characterize our own immune system, and that should be able to direct us and help us better decide how we will be treating our patients going forward. I think combination therapy will be the standard immune therapy going forward, that we likely are not to be using single agents in the future. And as I said, our real goal here is to have a precision immuno-oncology that will have hopefully the capacity to decide which of the combinations need to be added in to fix the piece that's missing. And I think we'll chuckle when we only look at PD-L1 marker now. So with that, I will end here, and we're not taking questions. Thank you very much.